This presentation is about behavioral health diagnostic coding. And really, I mean, it's to help you pick the best diagnosis so that it can map to the proper code so that there aren't any major billing issues with your patient's stay or encounter. So hopefully this clears up some questions you may have about picking proper diagnosis and how it maps when it's coded. Here are some tips for coding ICD-10 diagnostic coding for mental health codes. For diagnostic criteria, you want to make sure you're consulting the Diagnostic and Statistical Manual of Mental Health Disorders, also known as the DSM. Right now, they're on version 5. Again, they outline the diagnostic criteria for any mental health diagnosis, substance abuse diagnosis. It's all in there, and it's very clear what the parameters are in order to diagnose a patient with those specific mental health conditions. Number 2, remember, there are multiple severity levels in many behavioral health diagnoses. So make sure you include the severity level in any diagnosis where it is required. You want to look at diagnoses such as bipolar, depression, major depression, those substance abuse conditions. Mostly all of those will have different severity levels: mild, moderate, severe. Some of them also are coupled with psychosis, even mania. And it's that same way with substance abuse as well. So you definitely want to make sure that you're identifying those severity levels because it can make a good difference, and we'll go into that. Mental health severity levels range from mild, moderate, severe, and there are symptoms outlined in the DSM-5 of each. Patients have to meet certain criteria, and we'll go into that in order for you to diagnose them with those different severity levels. Always refer to the most current version of the DSM for your diagnostic criteria. Again, we're currently on version 5. I believe it took them like 20 years to update from version 4. So it's not something that's updated very often, but they do make changes to it sometimes on an annual basis. So you just want to make sure you're using the most current version of that diagnostic material, the DSM-5. And remember, specificity is everything. Accurate mental health diagnostic coding strongly depends on our providers being as specific as possible. We'll go into a few examples next. Okay, so diagnosing major depression disorder. This is a big one as far as your primary diagnosis. A lot of our mental health patients are diagnosed with depression. And so then there's a lot of opportunity for us to do better with the way we are diagnosing and making sure we're using those severity levels. So we'll take a closer look. Symptoms of depression. Depressed mood, such as feelings of sadness or emptiness. Reduced interest in activities that used to be enjoyed, sleep disturbances, not being able to sleep well or sleeping too much, loss of energy or a significant reduction in the energy level, difficulty concentrating, holding a conversation, paying attention, or making decisions that used to be made very easily. Then the last one, suicidal thoughts or intentions. So one of the 2 core symptoms must be present for a diagnosis of depression. So number 1, persistent low mood and feelings of sadness with or without crying spells. Number 2, marked lack of interest in a previously pleasurable activity. So when it's coupled with all 4 of these components, that's how you get the severe. And so a lot of the severity levels depend on having 1 or 2, 3 or 4, or all. So again, that's why you want to make sure you're well versed with what is required for each severity level. But if you have a combination of some of these things, but it's only hitting 2 boxes, then you're going to go with the lower severity, probably mild. And then, as you have all of them, it would be more of a severe. And again, you also have the opportunity to add the psychosis or the mania in bipolarity. So just make sure you're, consulting that DSM-5 for those added criteria. Okay. So when you look at that criteria again for diagnosing major depressive disorder, 7 additional related symptoms are there as well. Sleep pattern disturbances, change in appetite, tiredness, sluggish movement or agitation, difficulty concentrating or solving simple everyday problems, feelings of guilt and or worthlessness, thoughts of death or suicide. The 3 levels of depression characterized by the following: mild, and this is kind of what I was touching on the last slide, mild, 1 core symptom, and usually no more than 4 related symptoms. So one of the core, which would have been one of these, and then an additional 4 related, which would be 4 of these. Okay, so moderate, both core symptoms are present, as well as 4 of the more related symptoms. Severe, both core symptoms are present in most, if not all, of the related symptoms. So again, as you're diagnosing, when you're doing, your psychiatric evaluations or any sort of assessments, you want to pick up on some of the language the patients are using to help you get to the point where you're noticing their sleep patterns, their eating habits, whether or not they are suicidal. And of course, you have other assessments if they are that you'll need to do. But that's how you get to these different severity levels. Okay. And so diagnosing major depression disorder. So for a final diagnosis of major depressive disorder, the provider would select the code F32.9 for major depressive disorder, single episode unspecified. That's what it maps to. Okay. So that is just basic depression. Okay. If this is not the patient's first time being diagnosed with depression, then you want to make sure you're using a diagnosis that includes recurrent, because this would be another additional episode. It wouldn't be a single episode, because single episode indicates that this is their first time suffering from major depression. So again, if you're just putting major depressive disorder or MDD, it will map to just basic depression, which is F32.9. Okay, so again, if it's another occurrence, you want to use a code or a diagnosis that will have recurrent episode in the language. Okay. Also, code F32.9, which is just major depressive disorder, is the most mild of the mental health depression disorders, and it's typically not a severe enough illness to justify an inpatient stay. So if inpatient is recommended, or if this person is already admitted to a behavioral health facility or to the behavioral health unit in a hospital, just giving them the diagnosis of major depression sometimes isn't enough to support them being there on an inpatient level, unless you made it a secondary diagnosis. But as a primary diagnosis, it usually isn't enough. You will need to add the severity level. Mild, usually you probably want to go with moderate or severe. Okay, of course, that's if they're meeting that criteria that we talked about previously, but you definitely want to make sure you're adding your severity level. The F32.9, just major depressive disorder, is typically seen in an outpatient setting. And it's okay if, a lot of times patients come in with the severe depression, and once they go to the outpatient setting, it's kind of reduced. They're a little bit better, and it just goes down to a lesser severe version, which could be the major depressive disorder. Important consideration: without documentation of the severity level, the diagnostic code will always map to the lowest severity level. Okay, so that's basically what I'm saying. If you just put major depressive disorder, it's going to code as F32.9, which is the lowest severity, which is just basic depression. So if this person is meeting criteria and they have those 2 cores and those other symptoms as well, then you definitely want to make sure you're using a more severe diagnostic code, giving them more severe specificity on your diagnosis for major depression. Okay, important tips for substance use when you're using ICD-10 diagnostic coding, okay? Again, your diagnosis criteria will come from the DSM-5, but the codes are driven from ICD-10. So substance use disorder diagnostic coding is dependent on specification in the documentation as well. When you look at that criteria in the manual, you may understand more. So substance use disorders can be a bit more challenging to code in ICD-10. And the reason for that challenge is because the DSM-5 uses a certain language, which is use disorder. And that changed, you know, when the DSM-5 came out in 2015. They went from dependence and abuse to use disorder, okay? And so with the use disorder and the DSM-5, you will add severity levels, which are the mild, moderate, severe, similar to the depression and bipolarity that we were just previously discussing. However, in ICD-10, those same use disorders are still being mapped to use, abuse, and dependence. So you want to make sure, and then certain codes, I will also say, may or may not have the use coupled with it. And use is the lowest severity, okay? So as you look at this diagram here on the bottom right, use and abuse, those are two of the lowest severity levels. Some substances do not have a use component in ICD-10, and so it automatically will map to abuse. Okay, but if you're using language in your documentation of both use and abuse, either the coder or yourself will be using a code for abuse. Okay, so that's kind of what this diagram is outlining. If there is documentation for both of these severities, abuse and dependence, then you will assign a code for dependence. You will go ahead and say, this patient is dependent on cocaine. And again, basically, it all maps to the highest severity level when there's dual language. So unless you as the provider stick to that one thing, being abuse, abuse, abuse throughout the documentation as you're seeing this patient, then the coder or yourself, if you end up using dependence, you will end up coding it as this is a dependent condition. So be careful about that, because in the DSM-5, it does clearly outline the criteria for use, abuse, and dependence. And it's based on the frequency of how frequently the patient is using the substance that they're on. Don't quote me on this, but say the patient, smokes marijuana once a week, that would usually be an abuse tendency. It wouldn't map to a dependence for marijuana. So hopefully that makes sense. So just think of it in terms of that way. It's about the frequency. So you may want to just consult the DSM-5 quickly and just verify what the frequency is for the substance that your patient may be using, just so that you know what language to consistently use on that patient's documentation. Okay. And then again, there's the cheat sheet here. And again, you always map it to the highest severity level. Dependence is the highest. There is use, abuse, dependence. Again, severity levels are what the DSM-5 expects you to use. And that's pretty much the expectation of behavioral health for diagnostic criteria. You want to use the language in the DSM-5. And that is mild, moderate, and severe. Okay. Okay, important tips for substance use diagnostic coding in ICD-10. Be sure to consider the following when coding. Ensure the patient's substance use frequency matches the criteria for abuse or dependence or use. Abuse diagnosis does not meet criteria typically for a payer to consider this patient needing an inpatient stay. So what we're saying on that one is that if you just put patient uses marijuana, use typically maps to abuse once it's coded, okay? Abuse typically is not a severe enough condition or addiction to require inpatient stay. Okay, so that's what that is saying. So that's why it's important to use those severity levels, mild, moderate, and severe. If you're going to, write your diagnosis down in the language of ICD-10, then you want to make sure you're using use, abuse, and dependence. Okay, because abuse is not severe enough for inpatient stay. Again, you will see use as like a primary diagnosis more so in an outpatient setting. That's fine, but it wouldn't justify an inpatient stay clinically. Okay. If a provider were to give a final diagnosis of alcohol use disorder, abuse, you will use the code F1010, which is the code for alcohol abuse. And, all these codes, all of these diagnoses have several code options because you have several different severity level options. You have the option to add with withdrawal. You have the option to add with psychosis. So again, just make sure you're consulting the DSM-5 for all of your options, with delirium, all sorts of things when you're looking at substance use. And so you want to make sure you're mapping it correctly, because when it's coupled with those other factors, such as psychosis or delirium or with withdrawal, those are higher severities than even dependence. So just make sure that you're assigning those diagnoses adequately. Okay, common terminology to help with assigning diagnosis. Okay, alcohol abuse, drinking in excess, but not having a physical dependence. Alcohol dependence, also known as alcoholism. A person has become dependent on alcohol and is unable to stop drinking, even though alcoholism has a negative effect on a person's health, social relationships, and non-formal daily activities. Drug abuse, taking drugs in excess, but not having a physical dependence. Drug dependence, when the chronic use of drugs creates a compulsion to take the drug to experience the effects of the drug or to alleviate withdrawal symptoms. Hypnotics, sleep-inducing agents. Sedative, drugs that induce a relaxed state. Analgesics, drugs that relieve anxiety. Hallucinogens, substances that induce a perception of something being present that has no external cause. Nicotine, a poisonous alkali that's highly addictive and a compound found in tobacco. Inhalants, substances that are inhaled for their euphoric effect. Polysubstance drug abuse, indiscriminate use of multiple substances. And there has been some updates with assigning polysubstance use and dependence. You still want to make sure that you are in somewhere in your documentation outlining the substances the patients are using, and also making sure that you are descriptive with the frequency of the substance use. In some instances, it may be more appropriate to just say this person is dependent on cocaine, this person is dependent on marijuana and other substances as well. It's not appropriate to say polysubstance use, abuse, or dependence when you are talking about a drug as well as alcohol. You will always want to outline those two separately. Okay, again, they've made recent changes to this polysubstance addiction and use and abuse. So definitely make sure you consult the DSM-5 and make sure you're using that appropriately when it's necessary. Thank you for joining today and learning about some of this diagnostic coding. I hope this was helpful to you.